Welcome to The Relay, a podcast focused on improving transitions of care across the healthcare system. I'm your host, Val Emmons. And when a patient moves from a hospital into skilled nursing facility, assisted living community, a home health program, or back into the home, the risk of care gap increases. Important information may not follow that patient, subtle changes in condition may go unnoticed, and small problems can quickly become serious adverse outcomes. But assistive technology can help bridge that gap. And some of the modern monitoring that we have going on that is helping that digital handoff and tools that can give care teams a clearer picture of what's happening during the first 72 hours, which is pretty crucial after discharge. And their patients are at their most vulnerable at that time. And these technologies can help identify early warning signs of any sort of decline faster and improve communication between care settings. But today we're looking at how assistive technology can help prevent emergency department visits and avoidable hospital readmissions, which is what we all strive to prevent. But we'll also discuss some of the often overlooked part of transitions success that can have a major impact on patient safety and recovery. So joining us today are Jackie Vance and Amy Chidester. Jackie is a certified gerontologist, wound care specialist, infection preventionist, and certified dementia practitioner. And she is more than 30 years of experience in skilled nursing and long-term care facility. And she's also the president of the National Transitions of Care Coalition and creator of the award-winning blog, The Real Nurse Jackie. And then Amy is a certified gerontologist, licensed nursing home and assisted living administrator, and owner of R.A. Chidester Consulting, with more than 20 years of experience across skilled nursing, senior living, memory support, ventilator support, and behavior health. But Amy is also a published researcher and a former adjunct professor and international speaker who works to bridge that gap between technology and senior care, which I find is very interesting. So we're going to get down to it. Jackie and Amy, welcome to the Relay.
Thank you.
Thank you so much. Glad to be here.
So I want to start out with, I kind of gave an overview, but I want to hear what you guys have to say. So to begin with, what do we mean by assistive technology in the context of healthcare and transitions of care, especially?
Well, I don't mind starting. Age tech is kind of my forte. Most of my consulting practice these days is bridging the gap between what we call age tech, right? The gap, the aging services, and then technology. And the reason that there's such a gap, in my professional opinion, and what I see out in the field today, is that we have an industry that hospitals are typically really fast to accept technology. They're more fast paced. They don't have the patience for very long. When rehabilitation centers and post acute care, it's more of that, like you said, transitional setting where people are coming and going, but you also have people that live there for long term care. And so you have a longer viewpoint of what's going on. And that's where it's the monitoring type tools and software is incredible, because you're not only looking at that snapshot like in acute care, but you have a continuum, so to speak. You're getting them ready for the next level. You're not expecting them to pick up where they're at the next level. Like in a hospital, you're saying, hey, the post-acute care community, they can help you. They're going to help you do this. They're going to help you do that. But when you're moving and transitioning out of post-acute care, there's a step down usually to a different level of care, and you're preparing them for that safe transition. So being able to easily collect data and see that trajectory and trends and patterns is super helpful. I'll let Jackie talk from the clinical side of it.
Yes, thank you, Amy. From the clinical side, assistive technology can basically function to give data to your clinical staff, so that your clinical staff and your nursing assistants, your nursing staff and your practitioners can do what only they can do. It doesn't take a lot of people are nervous about technology. They're like, oh, it's going to take away my job. No, it's an adjunct for them to give them data so they can do their job better. For example, there's an assistive technology called remote patient monitoring. And this is something that will monitor the patient's vital signs. It can monitor if they're moving in bed or not moving in bed. It can even monitor their position in the room. So for example, let's say somebody fell off the bed. that would not be noticed until rounds were done. But now you're noticed immediately. As far as the vital signs, that is, as a nurse, your biggest clinical clue. If somebody's heart rate is going up along with the respiratory rate, um, that's a huge clue that somebody could be getting an infection or going into a heart failure episode or going into a COPD exacerbation. And, taking vital signs once a day, or in some cases, if it's a long-term care patient, some facilities only do it once a week. You actually need that information very often. Moving around in bed, if somebody suddenly isn't moving around in bed very much, that'll change how often that person may need assistance to turn or reposition in bed to prevent a breakdown. Then something Amy and I are very passionate about is new assistive technology to let us know exactly when someone is wet. Because when someone's incontinent and urine is staying, they're exposed to that urine for too long. And I will say the archaic 2-hour check and change that we gave to ourselves in this industry, CMS never asked that from us, Val. Never asked that we would have to check and change people every 2 hours.
Here,
But
here.
some yeah, yeah. Somehow we came up with that crazy thing and it's impossible. Nobody can do it. No one can do it. Right. And then you have the surveyor sitting there looking at their watch, ready to give you a citation because the nursing assistants aren't doing it. But if I know when somebody's wet and how long they've been wet, you can prioritize when they need to be changed. You're not waking people up in the middle of the night. You're not wasting briefs, right? Changing people when they don't need to be changed. You're morbidly obese residents who need two people, two staff members with your limited staff and a Hoyer lift, and you're getting them, lifting them up and then trying to change that brief. And it turns out that brief is dry and the morbidly obese briefs are outrageously expensive. You're not doing that anymore. Then you can learn voiding pattern. I mean, there's so many great things by assistive technology. Amy?
Agreed, and I can't say it better. The thing that Jackie and I both just had a webinar recently, and we were chatting about the fact that one of our major kind of single recommendations to executives and leaders in the space is to take the time to really shadow your workers, right? The boots on the ground, and see what they're doing. And it's enlightening, right? You get to see from the perspective of the experts that do this work all day long. And a friend of ours, Dr. Stefanacci, had a study where he found that 56% of an aide's shift is incontinence care, whether it's actually changing or cleaning or changing beds or cleaning the floor or writing fall reports because of it, or something that's happening in the incontinence world. And if you really think about what fits in that world, it's massive. It's huge. It touches 4 of the 5 QMs that are used to formulate the 5-star rating. It takes, if you really think about the process of toileting and voiding, there's transfer, there's balance, there's cognition, there's feelings, there's infections, there's environment. And just as Jackie said, with urinary exposure, back when I was speaking directly with families and about grievances, which I will remind you, the number one grievance was not having timely enough care, which is normally someone sitting and saying, I had to go to the bathroom and nobody would come and help me. And in those situations, I would say, in our normal, if you think about check and change, someone could be waiting every 2 hours. It's check and change. Unfortunately, that's the system that has been set up by this archaic system or standard. And people deserve more than that. And, as a family member, I've had loved ones in nursing homes. I've had loved ones in assisted living. I've taken care of loved ones at home. And, the voiding and transferring and that whole piece, it is very focused, right? It determines whether or not you can take care of someone at home or in the level of care that they'd prefer. They have to have that assistance. And if they don't, the plethora of adverse events that come from that. And so that's why assistive technology is so beautiful in this moment is because we are all busy. Caregivers are overstimulated and overburdened, and formal caregivers in the nursing home environment, people are shocked when they say, "Tell me about the roles in post acute care." And I say, well, you've got your CNAs and you've got your floor nurses and then you've got your leader nurses, and the individuals that are charged with finding those patterns and trends, right? Your floor nurses, they're the ones that are charged, and so are your CNAs at times, with identifying changes in condition. And they're just trying to keep up, right? They're trying to do that check and change. Like Jackie said, we're setting them up for failure, and hate to see that. And so that is why I get so passionate about assistive technology and the tools that it can bring. And even AI is amazing. I've seen some AI assistive technologies out there for reading medical records and trying to identify those risk areas so that you can put these interventions and these remote monitoring systems in play, and all these intuitive types of devices. It's an amazing time to be alive right now.
Amy, I'm glad you mentioned about the AI. There's a chart scrubber. There's several companies that have this, and the ones that I've looked at, the majority of them are very good. But no human could do this. It would take a team of humans to go through the chart and look at the MDS, look at the labs, look at the nurse's notes, look at the physician notes, look at the vital signs, pull all of that together, and then it can identify for you in a daily report who is at risk for going back to the hospital. And as you know, at NTOC, our motto, it's not a written motto, but our one motto is the best transition is one that never happens. Then we want to fix the other transitions that do happen. But the idea is, if I am a director of nursing in a nursing home, which of course I have been, and I'm having my morning clinical report, and I'm able to say, let's say, Amy, you're my LPN and you've got 40 people that you have to give meds to. You're pushing the cart. And without the assistive technology, I say, now remember, you have to assess all 40 people while you're giving meds 3 times during your shift, and make sure nobody's going into a COPD exacerbation or heart failure exacerbation or getting an infection, whatever. You can't do it. But Amy, if I said, yes, you have to eyeball everybody you're giving meds to, right? Somebody can have a sudden change of condition. But what if I gave you and I said, look, according to the risk report, Mrs. Johnson looks like she's gained a little bit of weight. Her respirations are increasing. Yeah. So I need you to get a hold of the doctor. Let's order some labs. I want you to go in there and check for edema, et cetera, et cetera. You just have to target that one person out of your 40 patients. And that, by the way, Val, that also leads to retention and recruitment. Because if somebody knows that they're making my life easier with the assistive technologies that Amy and I have mentioned and more, and my gosh, family confidence, staff satisfaction, it makes such a difference.
I can imagine because, visually with incontinence, like, that's if you're working at a daycare, that's a little bit different. You have to check people's, but you're checking children. These are adults and they have dignity. And no adult wants to be treated like that when they have to, and they don't even want to be changed like it's a diaper, But so I find that this is interesting because, there has to be better ways than some of these facilities are using, and you're trying to give them that direction. And I think that it's awesome because if you sit there, you can't let a patient like just sit there in that.
One thing Amy and I think would really like to talk about, because it's brand new. It really is, and it's amazing. And we are both consultants to this company, eTechRx for eBrief, because there's nothing else there like it. And when you talk about being able to monitor people when they're wet, there are some other things out there, but there's nothing like this. And what it is basically is a computer chip that goes in a very thin pad. It's not double padding, by the way. It is absolutely labeled as assistive technology. And it goes in the person's brief, or if they wear a pad, it goes on top of that, or even underwear. And what happens is if the person not sweat, are not a dribble. People dribble. That's okay. You don't need to change a brief if somebody dribbled. The brief or pad is designed to wick that away. But what it does is if somebody has urinated 70 to 100 cc's, this is so cool, Val, that urine literally turns on the computer chip. It turns it on, and then by radio frequency, it goes to a reader, which then goes to a tablet, and you know who's wet, and then it monitors how long they're wet.
Wow.
So, and then you have the data to know when they were changed. You know when they're wet. And so there's a couple really cool things with that, Val, clinically. So one is I can track someone's pattern. So now I might know that Amy urinates heavily at 6 a.m. I need to get her on the toilet before 6 a.m.
I do. I do. Yes.
Okay. Yeah. Well, you know what? I do too, Amy.
Yeah.
Um,
Yeah.
So, or, people actually diurese at certain times. They really do. So I might have to wear a brief sometimes during the day, but we know when we can kind of catch it. Also, think about nocturnally. I don't have to wake somebody up at night during that stupid check and change. And when you think of your patients with cognitive issues such as dementia, and you wake them up or depression, it
Yeah.
messes up their whole circadian rhythm,
Yeah.
and they're actually worse the next day. What
So
if
you just put this in there and then you'll know whether or not they're wet and you need to wake them up.
To just jump in there really quickly, I mean, just to go down as granular as, briefs, yes, do have indicator lines, right? That the color changing line that changes when you're wet, that type of thing. But how do you identify that, right? You have to look at someone's crotch. On top of that, if you're wearing a pull up, which a lot of memory care folks do because they're more cognitively impaired than physically impaired, most of them do not have indicator lines. So how are you checking, right? Those are the questions that I would ask your staff because it's very interesting the answers you'll find out.
I mean, I can't imagine an Alzheimer's patient. And then every time somebody comes in to check them, they put their hand or whatever and check them, and they're like combative. I can imagine because I would be.
Right?
Yeah. And then, now here's another good one. So let's say though, dehydration is often a problem. Let's look at the opposite for dry. What if somebody's dry for 6 hours? That's somebody that I would then call my practitioner. Let's get some labs. Let's start some hydration, whether IVs or hypodermoclysis. Let's get them going before the person gets dehydrated. Because right now they're just having a fluid and electrolyte issue. And that's really important. And then the other thing is, I've been in long-term care, you said yourself, over 30 years. And when somebody new comes and we hear that they have a history of incontinence, we have to do what's called a 3-day incontinent diary. Now, the way it's done now, Val, it does not work. We're supposed to go in and change their brief every hour,
What?
see if they're wet, and write it down. Or, if we've toilet them, we have to add that to this. Well, with the e-brief, you don't have to check them every hour. Now, we do have to be sure, very vigilant, that if they put on the car light, we need to get to them right away because we need to know if it's urgent incontinence, right? But I can do a QAPI study and look and see, well, that person wet their brief, but look, they turned their light on and someone went and turned it off and said they'd be right back. This person does not need brief check and change. This person needs high alert that we need to go in immediately when they turn on their light because the practitioners are waiting for that information so they can diagnose what type of incontinence it is. Never before has this type of data been available to people. And you know what? It's not that expensive. And then let's say, okay, now Amy is the executive director over 5 assisted livings. Amy can look down to the patient with the data that she can collect. Who's being changed, who's being timely, what group were they in? I mean, it's absolutely incredible. No
I mean,
one's had this data before.
I find that it is very incredible because I know that whenever there's a transition of care, there's information that's not gotten to maybe the assisted living facility yet, or there's information that was left out. So if you're using this assisted technology in the first 72 hours, um, you can like tap into things that weren't mentioned in the report or that they forgot to leave or that they didn't send yet. And those things matter in that first 3 hours of your care, from your facility, because if you
Yep.
don't know, you can't take care of things that you don't know. And you can also maybe notice things that the facility that sent the patient didn't recognize using this assistive technology because maybe they didn't use it.
Yeah, and let me just say this because I know Amy wants to jump in. Look at this idea, though. Right now, if you're checking and changing, you only know somebody's wet. But what if, I know this resident usually urinates every 2 hours or 3 hours. Let's just make that up. What if they're urinating more frequently? Because now I know because I have the detection device, right? So I know they're urinating now every 20 minutes. Guess what? That person probably has a UTI. So now I can get labs
Right.
and get them on an antibiotic
Before
if
it
they
gets
need it
blown out of proportion.
before they get septic.
Well, my dad, it's crazy you say that because that's exactly how my dad passed away. He had a UTI, he got
Mm.
septic, and they gave him the antibiotics, sent him back to the nursing facility. He got another UTI, sent him back to the hospital, and he was already septic. And
So
Oh, I'm
sorry.
so
yeah,
sorry.
so I agree. I completely agree. This
There's
technology is, I mean, if they would have had this technology, then they would have gotten it before it got out of control and the antibiotics couldn't kill it.
Yes, yes. And, a third of sepsis cases come from urosepsis. And that's frightening. And, it's just to kind of harp on and not to beat the dead horse. But Jackie, was saying with the check and change, one of the other things that executives don't sit and think about sometimes when you're trying to decide, or if you're categorizing in your mind that incontinence is just comfort, which it is not, or just a hygiene thing. But even the check and change and the staff changing, right? These are individuals, you're taking care of them 24/7, but how many caregivers are they going to have just in the 3 days that you're doing the bladder diary? I mean, they're going to have CNAs, nurses, housekeepers. They're going to have 3 shifts, most likely, right? Day, evening, nights, and then they rotate. And it may not even be the same people the next day. It may not even be, sometimes they do split shifts, right? Because somebody didn't show up for their shift. So now someone's working late, someone's coming in early. It may be someone that's never worked with them, or it may be agency who is completely new to the community. And they're walking in, right? They're there to help. Thank goodness, right? We're extremely lucky to have that individual to help us fill the shift. But when you say they're filling the shift, do they really know what's going on? Do they really know the last time that somebody's brief was changed? You know, that's something, and Jackie said, well, how did we used to do this? When I was actively running skilled nursing, I had a forte of going into communities that were troubled. And I typically was a person that could go in and get people off bankruptcy lists or special focus facilities that had major issues, and to be able to help them get through this. And a lot of the times, these buildings, they had odor problems, and everyone knows that there's the nursing home odor, right? And it stems back to urine, and it's somewhere. And I've even worked in buildings where just over time we didn't have anything better than briefs and things, and it just gets into clothes and mattresses, even baseboards, right? Because a lot of times, wood or even the vinyl can soak this up. The tile in the floor or carpets, it just gets into everything. And it's just inevitable to have that odor. And to be able to address those things from the absolute root cause is also systematically and operationally just, thank goodness for some insight. The way we would do the check and change in these types of communities, and the only way we could do it is you have a Sharpie, and your leadership that's assigned to rounds goes and you write your date and time and an initial on the briefs, and you go back and you look every 2 hours and you see, have they been changed or not? But how inconvenient and disturbing that is, but that was the best we could do. I know Jackie wanted to speak up on that one because I'm
No,
sure
I
she's
was
been
I
the
was
Sharpie.
I was just I was agreeing with you, but The problem we find, Val, from the pushback comes from the people who hold the keys to the money. And they really do not understand, as little as this costs, the return on investment. So, Amy talked about, the UTIs, and it's true. The longer urine stays on the skin, the bacteria builds up, you get UTIs. You get moisture associated dermatitis, which breaks down the skin, leads to pressure ulcers. Both of those, of course, affect your quality measures. Then the number one top reason of falls with injury is someone trying to get to the bathroom. And this assisted device takes care of that. So you're looking at not only affecting your quality measures, you are looking at survey civil money penalties, very expensive. You're looking at litigation. Plus, overall, of course, you're looking at the patient health, but we're talking about the money pressures. So you want to know about the money. Plus, you're going to cut down at a minimum 30% of your brief usage. And briefs are the most expensive cost in your nursing home. And then add on to that, you're cutting down linen, washing linens, clothes, washing bedroom floors, different things like that. And Amy talked about the smell. Well, that's not soaking into floors and linens and things. You don't have the linen basket sitting in the linen room full of urine. It takes care of all of that. There's so much more ROI because when your quality measures go up, your star rating goes up, your ability to renegotiate with your managed care organization goes up. Your hospitals, you'll get more referrals from them because they're looking at your star status. It all is tied in. Those are hard costs, not soft costs. And when you were thinking about, oh my gosh, I need to hire another full-time nursing assistant because this incontinence is getting out of hand. 80% of our residents are now incontinent. We can't keep up. Well, you can because you know who's wet and when they need to be changed. You don't need that other full-time nursing assistant. So there's a lot of advantages to a program like this.
Yeah. We're also seeing too, typically it is seniors that we are applying, incontinence briefs and this technology to, and for this podcast audience. However, a lot of times older adults that aren't quite seniors are also increasingly dealing with incontinence and incontinence challenges. And we're seeing, an increase of memory care units and long-term care units and ventilator folks. And those individuals, not all of them are heavily seniors. And so, you think about an individual who may have some behavioral issues, that's a stronger adult too, right? That is potentially cognitively impaired, whether it's a brain injury or whatever it may be, that they're going to fight you when you go in to do personal care. Well, how amazing it would be to be able to, instead of go in and say, let's just check, but to be able to go in and say, hey, let's go take care of this. You can get back to doing what you want to do, right? That conversation goes a lot easier the second way, and being able to know that. The thing with assistive technology, just in general, I love that you use that term because that is a new term to long-term care and post-acute care and just healthcare in general, right? Assistive technology comes from the disability community. That's a term that was utilized in insurances in that particular industry. And now that we're seeing all of these industries, thankfully, are no longer siloed, and they're starting to be able to help each other and work in that continuum and not in the silos. We're seeing that assistive technology is applicable to long-term care, assisted living, hospital at home, home health, home care. Assistive technology can be covered by other grants, by other things that states may have. There's a lot of states that are even considered technology first states. And those would be the states, try to engage with your legislators, try to go and find support for that information. And so it's not just, it's not an EMR. It's not a tool. It's a tool that is helping you. It's not just incontinence or something that's a part of your rate, right, through Medicare all the time, but it has something more to do. So I love that you're using the term assistive technology, because that's a fairly new thing.
Well, it is, and it's the way of the future, and I know that a lot of the time there's a risk that organizations may use technology, like, as a replacement for human observation rather than a support tool, but I think in this case, I think sometimes you don't sometimes patients don't want a human involved in that part of it, you know? I mean, sometimes they want to be monitored in that way so that their dignity isn't shredded, I guess you'd say. You know what I mean? Like, I think that that is a space where we won't have to worry about that. And of course, there's other assistive technologies out there for monitoring. But if they're not invasive and they're not taking over and they're used as a tool, people don't understand a calculator is a tool. A computer is a tool.
Yes.
It has to have a human behind it.
Yes.
So you're reporting this data to the human who is going to analyze that data. And I
Yeah.
think that,
Mhm.
I don't think that's a
Mhm.
real problem there. So as of some other ways of AI in healthcare might be.
Well, the system that we have all built in this industry, with the way inspections go and just the way the quality measures are written, and it's very outcome based, right? It's based upon, we all focus on, gosh, how are we going to stop these UTIs? How are we going to handle this wound once it starts? That type of thing. And it's less on the root cause side of things. And it's just the system in itself is so punitive. It's not a lot of carrots versus the sticks in the industry. And I hate that the system has been built that way, but it's just kind of where we've gotten to. And I think, we're starting to see the turn where we're starting to see in different states where states are saying, there's so much more out there for ways to proactively care for folks, and being able to identify small, subtle changes that can lead us down the paths that we just never thought of. I mean, gosh, you're in the hospital, and they're making sure you're not going to die in the emergency room, right? They're not going to sit and figure out where your reflux is coming from because it's something that makes you uncomfortable. They're going to make sure that you're not having a heart attack or, any other types of things that are leading to that, but they're not going to do deep rooted testing and, take that time to do that stuff, which we don't want them to, right? That's why we already wait 4 hours for emergency rooms. But this, in long-term care or post-acute care, you have people for a longer period of time, and having those trends, you're looking at a lot, right? Incontinence is such a powerful tool. Jackie was talking about just the skin, and studies show that skin begins to break down when it's exposed within 15 minutes. And if you go and ask any CNA, any family member, any resident, and say, how long do you think it's acceptable to sit in urine? Right? So, like, a family member is coming to you, let's say, Jackie, you're a daughter, and you've come to me and you said, mom said that she put on her call bell and she had to wait. And you say, okay, well, how long did she have to wait? And you say whatever that number is. Is that an acceptable wait time? And who makes that decision? That's very interesting. It's going to be different, right? Or Jackie, what would you say?
Um,
An hour,
Clinically, I say an hour, but, if
right?
I was wet myself, I might say sooner. I mean, people to understand the realistic goals. Realistically, we'd love to change everybody immediately. Then again, we don't know when people are wet immediately, but maybe we can know when people are wet immediately.
Totally.
I think, if more caregivers and families and patients knew of this kind of technology, that they would help push the drive to, because if I was looking for a place, or I would hope that if my children were and they knew of this, I would hope that they would look for a place to take care of me that had this kind of technology already.
Yeah. Well, that punitive system I was talking about that we've built, operators are scared of data. We're scared
Well,
of
because it can
handing.
hurt them.
Yes, yes.
Well,
And
that's why I would choose a place that opted to have this technology because
yes,
they're more worried about the patient than
yes.
hurting their reputation.
Well, and I think too, they don't realize that you're already handing over the treasure. It's no longer, we don't do MDS assessments on paper anymore, right? They're using tools at the state and federal level. They're looking at claims. They've already, they're using technology to find your vulnerabilities using your MDS data, your QM data, your self reports, all of these types of things. And so they've got the data. And wouldn't you want to have it before they do?
Sure. Thank you, Jackie and Amy, for joining us and helping us better understand how assistive technology can strengthen transitions of care and prevent adverse outcomes. As we've discussed, sensor based monitoring and digital handoffs can help care teams recognize changes earlier, share critical information across settings, and respond before a patient's condition reaches a crisis. But technology alone isn't the answer. It must be supported by a trained staff, clear clinical protocols, accurate handoffs, and a defined plan for acting on the information being collected. The goal is not simply to gather more data. It is to make sure that the right information reaches the right person at the right time. So providers can intervene earlier, protect patient safety, and reduce those unnecessary emergency department visits and avoidable hospital readmissions. I want to thank everyone for listening to the relay today. To learn more about the National Transitions of Care Coalition and access additional transitions of care resources, you can visit ntoc.org. That's ntocc.org. I'm Val Emmons, and we'll see you next time on the relay.
Thank you for having us.